Well, welcome everybody to our summer family training series, Empowering Family Leaders, Hope for the Future. This training is sponsored by Iowa Family Leadership Training Institute, who makes its home at Child Health Specialty Clinics, the Division of Child and Community Health at the University of Iowa Stead Family Children's Hospital. IFLTI is in its 6th year and has graduated over 50 families from its 4-session formal training. And in addition, we offer regional and virtual hourly sessions like this series. So we're glad that you're here with us today. And we're also glad to have Adrian, our Spanish interpreter, with us again today. So Adrian, if you'd like to take this time to connect with folks who'll be utilizing interpretation for this session, that would be great.
Thank you, Jody. Hola, buenas tardes a todas, a todos los que están presentes para esta presentación. Give me a quick second. Sorry, Jody. My phone is ringing too loud. Disculpen, mi teléfono estaba sonando demasiado alto para escuchar bien. Yo les voy a ayudar con la traducción de esta presentación en español. Si están viendo ahorita la pantalla, ahí les muestra cómo acceder el canal para español. En un momento, cuando estemos listos, Diane me va a poner en ese canal y ustedes si hacen clic en ese botón que les están señalando allá abajo a la derecha, aparece, van a ingresar a ese canal también, donde van a escuchar mi voz primariamente mientras vemos la presentación en vivo. De vez en cuando se escucha la voz del presentador también, pero se debe de escuchar más bajo en su computadora para que puedan escuchar la traducción bien. Entonces, si pueden ustedes hacer eso y los que van a ingresar ahí van a escuchar la presentación de aquí en adelante. So, Jody, yeah, I asked people.
Okay, I hope the trouble's not on my end. I got hung up there a little bit with Adrian, but I think everybody's connected. And we would just like to review a little Zoom etiquette here before we get started with our presentation today. So we ask that you would keep your microphone muted unless that you're talking to help with background noise. And also keep your video on if you're comfortable with doing that. I think it just helps us to have a more complete experience of togetherness for today. So finally, if you have any questions for our speaker, please feel free to utilize the chat feature throughout the presentation to chat those in, and I'll gather those questions for a discussion period that will open up at the end of the presentation. So today's session is entitled Leading with a Health Equity Lens. And in this session, we'll learn about the social determinants of health, as well as the differences between equity and equality, and how awareness of these things helps us to be good leaders for all people. So we're happy to have Alejandra Escoto with us today to lead us in conversation. Alejandra is the Title V Program Coordinator for Child Health Specialty Clinics. And in 2019, she earned her master's in public health from the University of Iowa. And she has several years of research experience in health equity and community engagement projects on topic areas such as e-cigarette use, rural health, and cancer prevention. Alejandra lives in the Iowa City area with her fiance and enjoys trying out new fitness classes, traveling, and reading. So I will turn it over to Alejandra to get started with today's discussion.
Thanks, Jody.
Sure.
Can you hear me okay?
I can hear you great.
All right, so I'm going to share my screen. So it might take me a minute here to get my screens together. All right. Do you see that okay?
Beautiful.
Perfect. All right. Well, hello, everyone. Like Jody said, my name is Alejandra Escoto, and I'm the program coordinator at the Child Health Specialty Clinics here at CHSC. And I'm so excited to talk to you all today about this topic about leading with a health equity lens. So to give you a brief overview of what today's presentation will consist of, we'll be starting by understanding health equity concepts and terms. We'll then move into discussing variables that impact community health, also known as social determinants of health. And then lastly, we'll be discussing how our own backgrounds and experiences shape the way that we view the world and how those perspectives might impact how you apply health equity concepts into your work as family leaders. And like Jody said, I'll also leave some time at the end for questions. And also feel free to message me in the chat and we can interrupt the presentation and go from there. So before we start, I wanted to take care of a few things. So I first wanted to talk a little bit about my credibility. And Jody gave a great little bio about myself, but I often find that when I'm doing, or when other people are doing presentations on topics such as health equity, the first question that comes to mind is, what gives the person the right to discuss or teach on this topic? So like Jody mentioned, I earned my master's of public health in community and behavioral health a few years ago, and I've been trained in health equity concepts throughout different projects I've been involved in. And these projects mostly focus on community engagement through the process of community-based participatory research. So you don't need to remember that name, but what it is pretty much is a fancy way of saying that we're developing healthy communities based on what the community needs versus what we as professionals or researchers think that they need. And although I have, these years of training, it does not at all make me an expert in health equity or social justice. And these are topics that you have to continuously learn about, but I'll share the extent of what I know, and, I will admit to places where I could learn some more. I also wanted to share my goal for this presentation, which is to create a safe space for discussion and learning. So I think it's really natural to be nervous to discuss some of these topics, whether it be that you're nervous that you'll say something wrong, you don't know how to approach the topic, or any other combination of things. So I want to make sure to state that this is a safe space to have those kind of difficult conversations if we need to, and that we're using this as a learning opportunity and a place to ask those questions. So I'm going to start off the presentation by building our foundation on health equity terms and concepts. So the tough part about defining health equity is that almost every major public health organization has a different definition of the term. So the definition I have here is from the Robert Wood Johnson Foundation, and it reads that health equity means that everyone has a fair and just opportunity to be as healthy as possible. And I chose this specific definition to share because to me it seems pretty simple, but when you're trying to understand health equity, I think this raises even more questions as to how the term health equity compares to other terms or what we call buzzwords that we often hear. So hopefully this next slide will do a good job at of helping you understand all of these different terms that we hear when we're talking about health equity. So oftentimes when discussing health equity, the question becomes, why can't we just give everyone the same access to resources? Wouldn't everyone be healthy then? And this then opens up the conversation of what does it mean to advance health equity versus promote health equality? So I've included a few images that will help illustrate the difference between not only equity and equality, but also comparing it to inequality and justice. And I think it's important to keep in mind that when you implement one of these situations, it will lead to dramatically different outcomes for marginalized populations. So the first image I have here depicts inequality. So one person is getting all the apples and the other person is not. As you can see, the structure of the tree itself is leaning a little bit to the left, and each person has unequal access to what we're going to call the system. So this is going to be a series of analogies, but the system in this case would be the healthcare system due to my line of work and the training itself. So in these scenarios, the system is more favorable to the person on the left, and therefore they can reap the benefits of the system. So the benefits in this case would be the apples. So our next question might be, why don't we make the situation equal for both people? So the second image I have here shows that each person was given the same ladder to be able to reach the fruit. As you can see, even with the equal support from evenly distributed tools, the access to the fruit continues to be unequal. To apply this to a healthcare scenario, although everyone might have access to the same system, not everyone will be able to reap the benefits of the system because the system itself wasn't built for them, or they don't have the proper tools to reach whatever benefits we're talking about. So then what does an equitable situation look like? So in this third image, you can see that both people received ladders, but the person on the right received a bigger ladder so then they could reach the apples. So this extra help leads to positive outcomes for both parties, and it comes from the idea of meeting people where they are. And I think that this idea is going to be something that you as family leaders can use moving forward, and we'll discuss on how we can do that a little bit later on in the presentation. So, while this equitable system seems good, it seems great, the system itself, so the tree, is still inequitable. So the ultimate goal in these situations is to make the system just. So by changing the structure of the tree to meet the needs of all parties, you can see that the tree now stands up straight and there's an equal distribution of the benefits, or in this case, the fruits, so that everyone has an equitable chance to reap the benefits of the system. So I know that was a lot of information. Does anyone have any questions there? And Jody or Diane, feel free to stop me if I can't see the chat right now.
Yeah, I don't see anything popping
Okay,
up in the chat.
perfect.
So
Thank you. All right, so I also wanted to share some more concrete examples of what it means to be equal versus equitable. So I wanted to highlight two scenarios here. So this first scenario, which is an example of equality, states that, at a community meeting where all members of the community are invited, and the meeting is about a local environmental health concern, the meeting is held in English, although English is not the primary language for 25% of its residents. So then, what would an equitable situation look like? That would mean that, the community hires translators to attend the meeting or offer a meeting held in another language. So as family leaders, you might often find yourselves in positions where you're organizing something, whether it be an event, a support group, a training, whatever it may be. And I thought this example might be good to make sure, that you all consider the community that you're serving and really know that community, so you're able to meet them where they are, and make sure that everyone's involved. So it goes back to the importance of really understanding, the community as a whole, not just within your social circle. So to go back to the 4 images depicting inequality, equality, equity, and justice, the overall goal of health equity is to ensure that there is social justice in health, so that no one is denied the possibility of being healthy just because they belong to a group that has been historically or has historically been economically or socially disadvantaged. So I often find that when people discuss health equity, they often lump the term health disparities into the mix. And I wanted to make sure that there's a distinction, that the distinction between the two is really clear. So that when health disparities are presented, that they don't necessarily equal health equity. So this is a definition of health disparities. So there are metrics used to measure progress towards achieving health equity. And you often find health disparities talked about in terms of like chronic disease, life expectancy, quality of life. A good one would be, X group has a lower life expectancy than another. That would be an example of a health disparity. So I wanted to make sure that you all knew the difference between the two. So without health equity, health disparities will continue to persist in our communities. And then according to Healthy People 2020, health disparities are a particular type of health difference that is closely linked to social, economic, or environmental disadvantage. So you'll often hear health disparities being associated with demographic factors. And demographics are usually used to measure health disparities, and those include things such as race and ethnicity, gender, sexual identity and orientation, disability status or social health care needs, and then also if you're rural versus urban. So with the particular population that we work with at CHSC, which is children and youth with special health care needs, we know that this population already faces health disparities due to their special health care needs status. And I hope that this conversation around health equity and health disparities highlights that when a child is already facing health disparities due to special needs, being a racial or ethnic minority, being LGBTQ or gender nonconforming, and living in a rural area, just as an example, might add to those original disparities that we're talking about. And when using the demographic factors to look at a child with special health care needs holistically, It might help them give their family what they need, and rather than looking at someone one-dimensionally. So I want to point out that having these demographic factors, for example, being part of a minority group, is not a bad thing. It just means that the system was not built for you. And we need to find ways to adjust the system so it's more accommodating in every situation. All right. So going back to our original slide where we broke down what health equity means, I think it's important to highlight what it really means to, have a fair and just opportunity to be as healthy as possible. And in order to understand this, I think we need to understand the concept of social determinants of health and how they might impact a person or a community's health. So the next question I want you all to ponder for a little bit is, are individuals responsible for their own health outcomes? And I think it depends on, your background and everything, but when I first saw this question a few years ago, I 100% said, yes, we're all responsible for our own health outcomes. And I think it's really easy to assume that if someone is in what you consider an undesirable situation, they have full responsibility in either preventing the situation or getting themselves out of that situation because it's based on individual behavior change. And I'll give an example here. So let's say someone is overweight. It's really easy to say if they exercise and eat healthy, then they'll get out of that situation. And I hope that in this next part of the conversation, I'll be able to explain some reasoning for why individuals are not fully responsible for their own health or health outcomes, and maybe try to convince you otherwise. So now I wanted to introduce this concept of upstream versus downstream interventions. So this analogy is something that's super foundational in public health. And what it is, it's making sure that there are safeguards in place so that people don't, here's another analogy, fall into the river and later need help or assistance. So as you can see in this image, there seems to be an issue that people keep falling into the river, and there are other people who are trying to rescue them out. But there aren't enough rescuers to save the people that, as soon as they fall in. So they have to rely on the ambulance down here that's downstream. So then the question becomes, why are all these people falling into the river? Why aren't there safeguards in place for when they do? So why aren't they wearing life jackets? Why aren't there boats in the river? Things like that. We're going to go on with this fake scenario. But a real life and pretty relevant example of this could be, our recent and still, I guess, ongoing COVID-19 pandemic. We know that vaccines, for example, are an upstream public health intervention, and that's one that reduces our risk of downstream interventions such as hospitalization. So I think that's a pretty, relevant and concrete example of something like this, whereas a lot of the situations that we might talk about, as family leaders might be a little bit different. So to better understand the social determinants of health, hopefully we can gain a better understanding about how proactively preventing these situations will help a person rather than waiting until the last minute and using more resources, as a community or a society. All right, so now I'm going to dive into social determinants of health. So social determinants of health are conditions where in the places where people live, learn, work, and play that affect a wide range of their health risks or outcomes. So I'm going to go through this graphic, and I think it really does a good job at helping us understand what all impacts a person's health rather than their individual behavior. So first we have education. So fun fact, education is one of the biggest determinants of your overall health. So whether or not you have access to early childhood education and development, the rates of enrollment in higher education, whether or not you graduated high school, and your language and literacy levels all impact in some way your health. Next, we have economic stability. So your employment status, whether or not you experience food insecurity, if you experience housing instability, and then if you experience poverty as well. Next, we have neighborhood and built environment. And this is something that I oftentimes forget about when we're talking about what impacts a person's health. But as I go through these examples, maybe you'll start seeing them. But here we have, do you have access to foods that support healthy eating? Is there crime and violence in your community? And does that impact the way that your behavior, does that impact your behaviors in a way that impact your health? What are the environmental conditions? A good example of this, especially in Iowa with our agriculture, is if you live close to a CAFO or like a big agricultural or industrial situation, that can impact your health. Also, your quality of housing too will impact your health. Next, we have, I think, the obvious one, which is health and healthcare. So do you have access to healthcare in general, access to primary care to catch those things early on? And then are you able to understand what the doctor's telling you and be able, for example, to take your prescriptions in the correct dosage and the times that you need? And then lastly is another one that I think people often forget about, which is your social and community context. So civic participation, are you able to vote for the policies that impact you and your family? And, do you feel comfortable doing so? Do you experience discrimination? Are there high incarceration rates in your community? And then also, social cohesion. Isolation is a big negative, has a big negative impact on your health. So how does that make you, how does that impact your overall health? So then, we're going back to the original question of whether or not individuals are responsible for their own health. And I feel like many researchers in this field argue that while individuals should play an important role in maintaining their own health, they should not be held entirely responsible for it. So their community should also be helpful in promoting health and preventing disease. So then our next question is, why are there health disparities in certain communities? And, as an example, let's say that public health professionals, so let's say, the Johnson County Public Health Department said that a specific community had increasing rates of obesity. So using a social determinants lens, let's see why that might be. So we'll start with education. So like I said, education is one of the biggest predictors of overall health, but it might not be in the ways that you think. So in the example of obesity, it might be that if a person didn't graduate high school, they may work in a job where they have less control over their own schedule or work odd hours, meaning that there's, a time cost associated with exercise or eating healthy that might not be as accessible to someone who has more control over their day-to-day activity. Next, moving on to economic stability. So obviously financial state is important in this situation. That impacts your food insecurity, financial stress, and then generational wealth. All of this impacts one's ability to save money, buy food, or have the leisure time to exercise. Moving on to neighborhood, if you live in a food desert, which definitely impacts non-white communities more than white communities, that's a big one. Is there crime? You don't feel safe going to the grocery store during those odd times that you're off of work. That will make you less likely to get healthy food. And do you have parks in your community? Are you able to use sidewalks, or do you even have sidewalks that you can use to exercise on? Next, we have health and healthcare. So obviously preventative care is important, and understanding what's healthy, what's not healthy. All this is important in making those healthy life choices. And then lastly, for social and community context, there's discriminatory zoning laws that have resulted in food deserts and more diverse communities. There might be a lack of social cohesion because maybe not everyone's off of work at around 6 p.m. and you can't go over to your neighbor to discuss, or you don't trust your neighbors, whatever it may be. So that's just scratching the surface of what how you can look at a situation through a social determinants lens. Excuse me. So I wanted to move on to the last section of the presentation. So I wanted to circle back on the purpose of this training, how family leaders can lead with a health equity lens. So we're going to start off by doing a short activity, and it'll be something that you can do, at your desk or wherever you're at, to help you understand how your background and where you came from might impact the way that you view the world and how others may view you. And then we'll move on to an activity on how language impacts the way that we see and talk about certain communities. And then lastly, we'll do a little case study on a situation that you may run into as family leaders as you're trying to enact change in your communities. Okay, so before I start diving into this last part of the presentation, I wanted to take some time to do a little bit of an introduction. So I know that we're 20 minutes in, but when I do presentations like this, I think it's important to be open and honest about my background, not only to have you all better understand where I'm coming from and my perspective, but also give an example of how understanding myself and my situation may impact the way that I view the world and in specific situations. All right. So I was born in New York, and it might not be, the typical New York that we see in the movie. So this is what I picture when I think of New York, but the reality, this is what it's like. So my parents immigrated to the U.S. in their late teens from the Dominican Republic and Honduras, and they both grew up in a very ethnically diverse neighborhood in the Bronx. So this picture here is actually the street that my grandparents still live in after about 50 years. And my parents did not attend a four-year university. Their highest level of education is an associate's degree. My dad's a dental hygienist. My mom stayed home with us and now works part-time. And for the first few years of my life, I grew up in a neighborhood very similar to this, mostly Spanish-speaking, lower income, what have you. So when people ask what it's like, when I show them this, I always refer to the play or the now movie In the Heights. I know it just came out, but that's a pretty accurate representation of what it's like, in case anyone was wondering. So when I was young, my dad's job transferred him to San Diego, but we soon ended up in Des Moines, Iowa. So as you can imagine, this is a complete 180 to the neighborhood I was brought home from the hospital to. So then I was introduced to what suburbia looked like, but my parents never owned a home. So I had a much different upbringing than my peers and my close friends. So then, I went to university. I was the first person in my family to receive a master's degree. So this is just scratching the surface. So as you can see, the journey to where I am today and standing before you is very layered. And you probably did not assume those things just based on looking at me or speaking to me, working with me, whatever it may be. So so the purpose of this is to think back about your own, journey. Where did you come from? How did it make you who you are? And how does it make you see others? We can't easily assume or make blanket statements about someone just because we know one thing. For example, if I said I was from Des Moines, you could assume one thing, but you don't actually know the true story. So I've only decided to share certain parts of my background. And this is not an exhaustive list of who I am, but I hope it allows you to take a minute to reflect on what makes you you and how your background might impact the way that you view the world today as family leaders. And maybe think about it, reflect, and then as we do like the next activity, maybe you can see how that goes. So when you're applying these skills of health equity and social determinants of health, I think it's important to understand how you frame your language when discussing communities and populations. So you can think about communities, in your head, but as you're trying to actually go out and implement something, thinking about how you're talking about community is going to be really important. And public health has long been responsible for framing certain communities as disadvantaged, rather than framing and using the deficits of a community rather than the assets. So this leads to further discrimination and bias and shifts the blame onto the individual rather than the systems responsible for the health disparities. So I'm going to run through some examples of, instead of saying this, you can say this. And a lot of it has to do with using, person first language in the disability world. But I'll run through those examples quick for you all. So maybe instead of saying that African Americans in this community have higher rates of diabetes, you could shift the narrative and say that diabetes is more common in neighborhoods that don't have access to healthy foods. So instead of shifting the blame on, and saying that the first one is assuming that African Americans don't make healthy life choices. But here we can say that it's the neighborhoods, the systematic injustices that might contribute to that health disparity. Instead of saying the Black community doesn't trust the vaccine, you could say that there's a history of medically misleading and abusing people in Black communities, which has led to a relationship of mistrust that must be intentionally rebuilt. And, history does say that marginalized communities do have medical mistrust due to historical situations that have happened and continue to happen. So then again, shifting the narrative to blaming the system rather than the individual. And our last example here, instead of saying that you help families with limited health insurance coordinate necessary care for their child with special health care needs, maybe you can rethink that and say, we help loving families of children with special health care needs access supportive services. So instead of, associating the family with their deficit, in this case, limited health insurance, shift it to the system itself is a little bit difficult to coordinate or access. All right, so I wanted to finish off the presentation by doing a little bit of a mini case study. So as family leaders, much of the work that you do consists of communicating with families in your communities and getting them together for an event, support group, advocacy session, what have it. And I wanted to focus on a scenario where you're designing a support group for families of children with special health care needs in your community. So let's say that you've marketed your event using flyers. You've talked to your friends about how, and asking them to attend. You've reserved a space in a local community center. It may seem that you've taken all the necessary steps in preparing for that support group. But if you can, start putting in the chat box or talk to someone or jot it down, whatever you want, about some reasons why families, especially, diverse families, might not be responsive or open to attending your support group. And I'm going to pop up on the screen some common issues that people find, or sources of frustration when working with families. And this is definitely not an exhaustive list, but I think it does a good job at getting people to start thinking about how we can use social determinants of health to shape the way that we view leadership challenges. And I also think that this helps shift the blame from either blaming a certain family or community for not attending things or being unresponsive to being more intentional about blaming the system or injustices that might be contributing to the issue or behavior. So I'm going to pop up some reasons. Actually, I'm going to see what you all have said. So Diane says, they don't know me, so trust hasn't been built. Nicole says language barriers, fear. Yep, those are all great ones. Families might not know if they will know anyone there, what to expect at a support group. Yep, that's so true. All right. Now understanding the culture of the group doing things, marketing and promotion may not reach minority groups. Absolutely. So keep those coming, but I'm going to throw up, on the screen some things here. So this might not be directly related to our situation, but let's start with insurance status. So it may be that families might have preconceived notions of what's covered by insurance and what's paid for out of pocket, especially if they don't know the system. So by taking the time to explain this, it might not only help the family, but also help build, rapport with them as you continue to work with them. It might be that they think that, a support group, maybe that's an unknown concept or a foreign concept to them. Maybe they think it's some sort of medical service. We don't know. So explaining, the reasoning behind why you're doing things might be important. Moving on to documentation status. I know Diane, I think, mentioned this in the chat box, but it's important to be aware that documentation status might be a barrier in certain communities. And depending on the situation, a person's documentation status might affect the social services that they receive, and it may also make them nervous to be talking to someone within the healthcare system, or people in their community that they don't know or they can't trust. Moving on to linguistic challenges. So obviously being able to discuss something with a family is pertinent on whether or not you're able to communicate with them. So I know that it often takes more time or extra effort to go through the process of finding interpretation or translation services, but building this into the time needed to meet with the family and using the resources that are available to us may help even out the playing field. Um, and finding those trusted leaders within your community that might be within that cultural group to help you in that process as well. Next, we have health literacy. So the system itself, especially navigating the system with as a parent of a child with special health care needs is super confusing and stressful. And maybe the family just doesn't know, what to do. So being that support person that's patient and understanding things might help support the family and be a family leader. Next, we have cultural norms. And I know that this was mentioned a little bit in the chat, but I want to be clear that we shouldn't blame other people's cultures or cultural norms for their health behaviors. But I do think it's important to understand how a community's cultural norms might impact the way that they perceive health. So I'll go into a little bit of an example, but when I worked at the College of Public Health, I worked with a community here in Iowa City focused on improving maternal health. And there was a situation where a pregnant woman had a health emergency and refused to have medical intervention because her husband was not there to approve of the procedure. So obviously, us, the medical providers, were all confused because, you would think that her as an individual would be able to make this kind of decision and she doesn't need someone there to quote unquote approve. Turns out having a unified approach between partners during childbirth is something that is culturally valued and super sacred in their community. So this is something that the providers did not understand because we didn't take the extra time to understand, maybe their birth practices or cultural values. So it wasn't that the woman didn't care about her child or herself. It was that it was completely out of her cultural norm to make that decision without her partner present. So being aware and understanding the communities that we're serving will lead to less confusion and more positive health outcomes. And to be honest, better relationships with as you as family leaders and the community that you're working with. I also want to point out that maybe we've had one experience with a specific group of people. We can't make assumptions or generalizations about cultures just based on that one experience. So it's important to steer towards learning about people rather than assuming. Another example of this might be that you're advertising your support group or event through email or social media. Not everyone has access to reliable internet. And not every cultural group is going to attend an event if a close friend or community member didn't personally invite them. So the key lesson here is knowing your community and then adjusting your behaviors or your strategies to have the greatest impact or reach as family leaders. Next, we have generational and lived trauma. So I think someone mentioned this too, not being willing or ready to share personal information, or feelings of shame, whatever that may be. And there have been systematic inequities and discriminatory practices that have led for communities of color to be weary of medical professionals in the medical system. So, this has been super well documented. I won't get super into it right now, but a sense of fear for whatever reason within a community might absolutely impact the way that community builds a relationship with you as a family leader. Next, we have rural-urban divide. So I'm sure many of you know, the lack of resources in rural settings and the overabundance of resources in urban settings is something that we absolutely see in the state. And we see it in a variety of different ways, including, access to medical care. So understanding some of those specific challenges to that rural urban divide might help build those relationships with people. Is there anything else that I may have missed? I'm looking at the chat here. I think a big one that Diane mentioned is that, they don't know me, so trust hasn't been built. I think that weaves throughout all of these different examples, that if you're not present in a specific community, what makes you think that they would be, willing or accepting to come to your event or your whatever it may be. So I'm going to move on to the next slide. Oh gosh. All right, so I wanted to end off the presentation by highlighting some things that you all can consider as family leaders. So the first thing is systems level thinking. I want you to come out of this training being able to think broadly about all cultures. So identifying that you yourself have a cultural background and that others do as well. And I hope that generalizing or stereotyping is not the norm when interacting with others that are different than you. I also hope that you leave understanding that cultural responsiveness should not be an afterthought when you're a family leader. Just like the examples I gave earlier in the presentation about, the translation at the community meeting, I hope that meeting others where they are crosses your mind as you start to lead within your own communities. And I also hope that the discussion on if individuals are responsible for their own health opened your eyes to shifting the narrative from blaming the individual to blaming the systematic inequalities that are causing these individual behaviors that we're seeing. And lastly, I hope that you'll continue to center those with lived experience in all of the leadership activities that you do. As you all know, your own children with special health care needs, they have a voice and their experiences and perspectives matter. So centering those voices that are often silenced by systematic injustices will be a crucial part to becoming a strong family leader in your community and beyond. So I'm going to open it up to any questions. Thank you so much for allowing me to speak this afternoon. My email is here in case there's any additional questions. I'd be happy to answer them.
Thank you so much, Alejandra, for this great presentation and eye-opening perspective. I think it's very helpful just to challenge ourselves to look at things in a new light. And yeah, any questions or comments, discussion that you all would have to share would be great. I just wanted to point out that this portion of the session will not be recorded. We'll go ahead and stop the recording just to encourage discussion and to respect your confidence.